All right, next we're going to have surgeries. So sometimes can be used to diagnose for and diagnose what's going on if we're not sure what type of cancer the patient have. They can also be done as for palliative and even reconstructive surgeries. So most of our cancer patients are going to go undergo some type of surgeries, either in the beginning or in the end of receiving it. They're going to have biopsies, and this is normally the biopsy so we can determine what type of cancer it is, so we know the type of treatment that we need to give our patients. So they're going to go on a different kind of anesthesia in order to determine if it could be local anesthesia or general anesthesia. Do we need to put the patient to sleep? Depends on what type of biopsy that they need to get. They can even can do needle aspirations in order to go in just to remove just enough tissues to be able to look up under the microscope to determine if the area is malignant or if it's benign. So the least invasive the tissue damage is, the better chance and the less of scarring. Okay, here you have your incisions, and this is your most frequent small, it's easily accessible to the tumor, such as on the skin or the breast, the GI tract. Sometimes the entire tumor sometimes can be removed marginal by incision. It's also visualize the entire tissue and the specimen, and it also can determine the type of grade that it is. All right, next we have the biopsies. This again, you have a different type, which is going to be incisional. And if the tumor mass is too large to be removed, they making like a wedge, forming the tissue to try to remove enough to try to do what they need to do. Both the incisional and the excisional biopsy are usually done through an endoscopic indirect visualization. So with the direct visualization may be necessary to determine how deep of an invasion it needs to be. The entire abdomen may be open with multiple biopsies removed. Okay, so now you have different biopsies here. You have your needle aspiration, your fine needle aspiration. So these are the different types and which ones they use for each one. When we're dealing with surgery, the removal of the entire tumor, and you're going to call this debulking. That's what that is when they remove everything. And it's also going to be used to remove any or the evolved surrounding tissues such as the lymph nodes. And it's normal like with our breast cancer women when they're doing a mastectomy. That's going to be your salvage surgery, the mastectomy after less intensive primary approach of the example. So they need to go in, they need to remove everything. That's going to be like a radical, and they're going to remove like the adjacent tissues, the lymph nodes, the tumor itself. And then local excision is going to be, they're going to move just a small amount of the tumor, and that's usually done on outpatient. So just kind of like know the difference between a local excision wide and the salvage surgery. Okay, this is this young man here. This is where they had to go in and remove the lymph nodes. And yes, that's a live person, which is this young man that's up here, where they went in and removed. So they went in, they removed all the lymph nodes here, and this is how they sewn them up. All right, prophylactic surgery. This is removal of a non-vital tissue or organ that are increased risk for developing cancer. Facts considered before the type of surgery. This is when you have that genetic marker, and this when Angelique Jolie. That's when she went in and she had electively had both of her breasts removed because she did have the I think hers was a HERS negative receptor gene for breast cancer. So she was going to get breast cancer. If not now, it was going to be later on in life. So she did the elective surgery to have both her breasts removed. A lot of people frowned up on it, which you should not, because that's her body, and she know eventually she's going to get it. So that was the best thing for her. So she had the mastectomy. If it was me and if I was in her shoes, then I would have done the same thing. So there is no potential risk or benefit from it, but it's just up to you however you want to do it. The ability to take the cancers very early and patient sets a post-operative outcome. So, like I said, there are some genetic tests that can be done to determine if you have a family history of or warranted to have the prophylactic surgery. And it's becoming more common than none. If they know they have a genetic marker of it, And believe it or not, some insurance, for some apparent reason, feel like they don't want to pay for the surgery. That is like the craziest thing to me. I think it would be easier for you to go ahead and pay for the surgery now versus trying to pay for everything else later. That's just my take on it, but some insurance companies don't think that way. Then you have your palliative surgery, palliative radiation, palliative chemotherapy. And this is normally when surgical cure is not possible for a surgical intervention. So they try to do something that's going to relieve the symptoms and make the patient comfortable. And it's the same thing when they do for it's like radiation. Palliative is not to cure it, it's to make the patient as comfortable as they can to give them the best quality of life that they can while they're here. Okay, then you have your reconstructive surgery. So here you see the patient. She had some type of tumor on her nose. It was probably with some kind of myeloma from sun exposure, and they went in, they removed it, and so she had reconstructive surgery. Okay, this young man, he had reconstructive surgery on his face, so he had some kind of probably area on his face, probably from melanoma, being exposed to the sun. So it's very important that you protect your skin. I told you the darker the melanin that you have, that kind of helps protect your skin from sunburn and the exposure of these different type of skin cancers. If you don't put sunscreen on, these are the things that can happen. So you can see this is the before and this is after reconstruction, after they fixed his face, and then now you barely can't even see where they had it done. So you can see the different stages of the healing. When they have it, you want to make sure that they're not immunocompromised and they have these surgeries because their body needs to be able to fight off any kind of infection and to prevent any kind of infection. So they normally start them on antibiotics before the surgery, during the surgery, and after surgery to make sure they don't have any issues. Nursing care during the surgery, you have your pre-op, intra-op, and your post-op. The best time to teach your patients about what to expect during, before, and after surgery is going to be during your pre-operative stage. That's because they can have a better understanding. You can't teach me nothing post-op because if I'm out of it, I'm out of it. You can't, then you're not going to be able to teach. So you need to be able to teach them the signs and symptoms of infection, what they need, what impaired wound healing looks like, what they need to be looking for is pain, to determine if they're going to have any kind of anxiety of it, the effectiveness of the surgery. So you're going to be hand in hand going over everything with the doctors as well. So that's what our things are for nursing care. Then you have your graft versus host disease. That's here. I'm not going to cover this further. You can go back and you can read through the information in the book, but this is what it looks like. And this is the ways how you need to be able to prevent it. So it's in your book. It's very long and detailed, so you guys need to be able to read up on that. Okay, now you have your monoclonal antibodies. This should be very clear because I've said it a couple times throughout this lecture. We also have monoclonal antibodies now for patients who have been exposed to COVID. We do have a medication that we can give them, but it has to be given on an outpatient setting. It is used alone or in combo with chemotherapy, but just know we do have it also with COVID now as well. So you'll probably be hearing about that more on the news as time go about, and it is given by IV. Hormonal treatments also can be used, different approaches in the care. Some cancers need certain hormones to help them grow and to thrive. Breast cancer needs certain female hormones, and prostate cancer thrives with testosterone. So the presence of certain females. So certain hormones we have to continue to give patients to kind of replace. Now, it depends on the type of breast cancer that you have. If it's HER2 negative or triple negative, you cannot take hormone replacement because the cancer is going to feed off the hormone. So therefore, the doctors have to figure out what initial treatment that you need to be on in order to have a quality of life. Okay, hormone treatment meds. I told you guys about the tamoxifen, and this is one of your medication that's on there, and it's used to treat breast cancer in women. Most common hormone treatment also in male that can be given for breast cancer. We use for prevention in breast cancer in high-risk patients. There will be a person, like say a first degree relative. Okay, I'm gonna give you guys an example of me. For example, like for my mom. I am not on tamoxifen as of yet, but that's one of the drugs that the doctors think about putting me on because my mom did have breast cancer, but they caught all of hers like in the beginning, so she did not have to have chemo or radiation. She just had to have surgery. So as of right now, I'm just taking just vitamin D supplements and vitamin E supplements. It hadn't got to the point now where they think they're gonna have to put me on tamoxifen, but they are watching it, and so just look for the side effects of that, because you need to kind of like know about tamoxifen. So make sure you look at your prototype of that. But these are the people that doctors often give the tamoxifen to. Okay, another one is going to be your Lupron. I told you this is what we give the patients for, like with their prostate, if they're having issues with that, and it had with the decrease in strong testosterone level. And it has been approved to give to some women. We give to them for as a hormone. I've only given it in 2 patients that are female that have had a history of breast cancer. Other doctors do not give it, but we can give that to them, so you guys can look at that. On your prototype 2, on who can and cannot, and side effects that you need to be teaching your patients. If we have a patient teaching moment, if you have a question on about Lupron, you know how you need to address it to teach your patient, as well as all the other side effects of the other medication that I've given you guys. Barriers to cancer diagnosis and treatments. Financial resources, limited insurance to the uninsured, low education level of health literacy, lack of transportation. Age of greater than 75 tend to be less attentive to the signs and symptoms. Comorbidities, if they have any different kind of comorbidities. If they have any kind of psych issues, depression or cognitive impairment, chronic pain or impaired mobility are some things you want to look at. If they are on limited resources, then the 9 out of 10, if they're going to be able to afford their treatments, it's going to be kind of hard. We do have some pharmaceutical companies that have paid assistance that kind of help our patients with their cancer treatments. Some pharmaceutical companies give our patients their chemo for free. They have to show they have a financial hardships, and we have 2 cancer navigators that advocate for our patients, and they help them with the paperwork, and they submit all the information into the pharmaceutical and drug companies, and they get their medications for free. They can even their chemo for free, and they even can get their pre-meds for free, and they can even get, if they have to have Neupogen or Neulasta or Procreate or Epogen, those other things to help them while they're doing their treatment. They also can get those medications for free, and our cancer navigators will help them with that. If they have any other comorbidities, such as like hypertension, anything like that, that's going to cause them to be able to not be able to get their chemotherapy because different things interact and they just can't afford it. If they have lack of transportation, they can't get there to get their chemotherapy, then guess what? They're not going to get their treatments. So we have to look at all that, and those are some of the barriers that's going to cause issues with our patients with cancer. So let's look at these steps on how we can help. So you have your steps to pain. You want to do your non-opiate and your adjunct, which is going to be your step 1. Then we're going to go into your opiates, the mild, moderate pains. And then you have your opiate to your moderate to severe pain. So your step 3 is going to be like your IV pain medications, your higher level medications when you're looking at that. And when we get up onto the severe pain, those patients that normally on those higher doses, those are the ones that are pretty much are about to be transitioned over to hospice. So they're going to be on morphine extended release, and it's going to be morphine 60 milligrams. They're going to be put on Dilaudid 4 milligrams PO, or sometimes IV. And if they're on IV, any kind of Dilaudid, they're definitely going to be in hospice, and the hospice nurse will have to come out and give those IV pain medication. When they're on the mild to moderate, you're going to be looking at your patients that's going to be on your Percocet or your Norco, or they could take a low dose of just regular Tylenol. And then on your step 1, it's just going to be your non-opiate, and it's going to be your general Tylenol 500 or your Tylenol 650 with that force pain. All right, so when we start our pain medication, when we start out with a non-opiate, once the pain progresses, we move to extended release pain medication, 4 hours, then 6 hours, and 8 to 12 hours. If breakthrough pain persists, we have immediate release medication available to address the pain until the next extended release medication is administered. So we do objective medications to help with the pain. So sometimes we have to combine non-opiates with opiates in order to help with pain relief. So that's when we do the patient education to tell them how they need to take their medication, when, and not to none. Okay. So you just want to make sure that you know how to do a good pain assessment to determine which medications you need to give. And when you're in the hospital and when you're with me or with any clinical instructor and they have a lot of pain medication that's on there, you need to know, and on there it's going to tell you, it's going to give you parameters on the pain level on which medication you need to give. So if you're charting a pain level of a 4 and you give your patient IV Dilaudid, that's a you did not give the right pain medication based on the pain level. So you're at risk of getting into some serious trouble because you documented that your pain level was a 4, but you gave them IV pain medication. Well, technically, you should have given them regular Tylenol. Now, if their pain level is like a 6, then that's when you're going to move into like your Norco or your Percocet. And then if your pain level is a 10 or greater, then that's when the IV pain medication is warranted. So just pay attention to that when you're taking care of your medication, your patients, that you're giving them the right pain medication warranting whatever pain level that they're exhibiting. Immunizations to prevent and treat pain medication. Then you have your Gardasil. This is going to be for your HPV to prevent cervical, head, and neck cancer. The age limit on it is up to age 22. If you guys do watch TV, you can start paying attention because now they're starting to promote Gardasil a lot on television. I did not give this as your prototype, but this is on your slide, so you do need to be made aware of it because I am giving it to you. It may not be a prototype drug, but it is on the slide, so this is information that you can be tested on. So you just need to know why we treat the patient, who's eligible for it, and why we're giving it. Okay, what does the cancer does to our body? What are some of the common symptoms? What are the biggest risk factors? What is the most common type of cancer? Why do people with cancer lose weight? Why do they swell? What does cancer grow, and what's the cause of death? Do all cancer cause death? Are all cancer curable or treatable? So when you're looking at cancer, these are some of the questions that you need to be kind of like asking yourself. Is the patient undergoing different diagnostics for the cancer? So these are some other questions when you're going through your PowerPoint and you're going through your readings. These are the different type of questions that you need to be asking yourself when as a study guide. These are some more other questions that can help you with your reading. So you know how you're grading. I gave you a table that's in that's going to help you with that as well. When your patient is getting radiation, when you're reading under your radiation under here, these are some of the questions you can kind of like mark off and kind of like go through to give yourself the questions that you need to be able to get better understanding of what's going on. When they're getting chemo, is it IV or is it PO? What does the medication work? How does it work? How does it affect the body system? There's some other questions you can be asking yourself when you're doing your readings. Who can administer it? These are some more other questions. What are the things that we need to be teaching our patient for? Skin, mouth, GI tract, what type of labs, what kind of mood that the chemo is going to put the patient in, what it's going to do for them, what other systems is going to affect. If the patient got to have surgery, what type of surgery are there? You need to know the different type of excisional. What is a biopsy? What is palliative? What is considered reconstructive? What are some things that need to follow up for surgery and what to expect? These are some more other questions that you could be asking yourself when you're doing your readings. What am I worried about an infection with cancer patients? What are some things that you need to be looking for? What are some things that you need to be teaching yourself and teaching your patients when they're taking care of themselves? For us, like eating and diet, I kind of like went over all this with you. What are some teachings they need to be doing to prevent constipations and diarrhea? These are some other things you need to be looking at. If they have stomitis, what is stomitis? How can it be treated? What are some early signs of it? What can I do in order to help them to prevent stomitis? Losing weight, how can I help them prevent to lose weight? These are some other things and questions. And I told you all about Megace and what it can and what it can do. When we're talking about fatigue, fatigue can cause nausea and vomiting, anorexia, lack of sleep, pain, anxiety, itching, coughing, interrupting in their sleeping. You need the different type of side effects and disturbing of the sleep, shortness of breath, and interruption. All of these things that can cause fatigue and pain. What am I worried about with my patient when they start bleeding problems? What do you need to be worried about? How can you monitor it? How can you help combat that? If they have shortness of breath, how can I teach them? What are some of the labs and what I need to be looking at? So you need to know your normal lab values. You need to know what is a normal H&H, what is a normal RBC, what is a normal WBC, what is normal platelets, what is your normal BUN, what's your normal creatinine, what is your normal liver function test. All these things that can come back with chemo that can be destroyed. You need to know those normal lab values. What can I do to help with my patient? What do I need to report to my doctor when I'm taking care of the patient? And these are some considerations for childhood cancers. These are the signs of childhood cancer that you need to be looking for. Continual unexpected weight loss. Headaches are often with vomiting and nights and early morning. Kids that can have increased swelling, persist pain in the bones, joints, and back and legs. And I told you all if they have supravenous cava syndrome, that is a medical emergency. What does it look like? What do you need to report to the doctor? If the child has any kind of lumps or masses, especially in the abdomen or the neck, development of excess bruising or bleeding or rash, that's going to be with their platelets. And then with cancer, constant infections, the child, whitish colors behind the pupil, nausea that's constant persistent with or without nausea medicine, constant tiredness or noticeable paleness in their eyes, their vision may change, or suddenly they can't see, or recurrent fevers from an unknown origin. So these are the things that you need to be looking out for a child with childhood cancer, okay? So these are the acronyms for childhood cancer. These are the things you need to be looking for. These are the things that you need to be doing patient teaching with your family member. So this is all I have for your cancer. Just make sure that you're doing your readings. If you have any questions, you know how to reach out to me, and I will see you guys on the wrap up.